Everyone, my name's Anne. I'm an intern and Carlin, and I'm going to be presenting on colorectal surgery. So I just want to check that my slides are present. Can someone give me a thumbs up or something?
Yep, it's present. You can see.
Good. Okay. Thanks. Okay. Great. So the way that we're going to go through it today is I've got 7 case studies with just a brief clinical stem and then an approach to how to assess for the presentation, and the presentations will cover a few different common pathologies, which are bowel obstruction, both small and large, inflammatory bowel disease, appendicitis, diverticular disease, colorectal cancer, anal and perianal disorders, and hernias. So we'll get started. So I think one thing that's common to any pathology for anything that might be surgical, you should include the following things, finding out whether the patient's fasting and when their last meal was, finding out whether they have appropriate IV access and are they being given maintenance or resuscitation fluids. Always get the same baseline investigations for any patient who's being admitted. Sometimes you might want to do amylase and lipase or troponin if they have, for example, pain that radiates to the back or epigastrium up towards the chest. Everyone will need some form of VTE prophylaxis. Consent for transfusion with a blood group and hold. Review their medications to see whether you want to hold or give them both pre and post-operatively. So especially important for things like diabetic medications like gliclazide, insulin, any anticoagulants, and then always making sure that they're comfortable with things like analgesia, antiemetics, and aperients, especially if you're giving them opioids. Checking their resus status, so would they actually be for surgery? Is that in line with their goals of care and their physical fitness? And then contacting the relevant admitting team for a consult. That's if you're in ED, obviously. So long as you say all of those things, I think you're on track for the management for each OSCE station for surgery. So the first case is a 17-year-old female called Kate. She's a high school student, and she presents to the ED with a 2-day history of abdominal pain associated with nausea and anorexia. Her past medical history is significant only for asthma, for which she takes regular Seretide. On examination, she has mild tachycardia of 105, rest rate of 22, she's febrile to 38 degrees, and she has a tender right lower quadrant. You've done some bloods. The only thing that came back abnormal was a white cell count of 25, and she is in the holding bay at radiology waiting for a CT of abdomen and pelvis. What are some other things that you'd want to look for, both on history, exam, and also further investigations to go through some differentials? And if I don't get any volunteers, I'm going to pick on a few people so I don't get too sick of listening to my own voice.
Has she ever had something like this happen before?
Yep, so full pain history, including previous episodes, severity, location, character, onset, offset factors, and precipitation, all that kind of thing. How about exam? Anyone want to chip in there?
Like classify if she's peritonitic, and
yep.
If she is, if it's localized or generalized.
Excellent. Okay. I'll put you guys out of your misery and get on to the further information. So obviously, young person with raised white cell count and right lower quadrant pain, one of the top differentials is going to be appendicitis. And so you want to perform the specific tests for appendicitis. So Robsing's sign of cross tenderness would indicate that there's peritoneal irritation. SOAS sign would indicate that there's a retrocecal appendix, and obturator sign would indicate that there's a pelvic appendix. So you wouldn't necessarily expect any of these signs to be present to diagnose appendicitis, and you wouldn't expect SOAS and obturator sign to be present at the same time because you can't have an appendix in 2 places, right? So other differentials that you want to investigate are gastroenteritis, renal calculus, pancreatitis, cholecystitis, mesenteric adenitis, PID, or other gynecological things like preterm labor, placental eruption. Those are pretty easy to rule out. Can anyone give me one simple bedside investigation? She's a young woman of childbearing age.
Should be A1C.
I think I heard a whisper of pregnancy. So in this case, as Sophie correctly said, you want to check for peritonism to exclude perforation. Other red flags to look out for are changes in the menstrual cycle, any PV bleeding, date of last menstrual period for ectopic pregnancy, and dysuria or hematuria for UTI, renal calculus, pyelonephritis, that sort of thing. So in addition to the workup mentioned in the first slide, you'd also want to do a septic screen specific to this patient, which would include blood cultures, urine MCNS, and urine NAT to look for STIs, to exclude PID. And also because you think that she's got systemic signs of infection, you want a lactate as well. So in terms of imaging, you can either do an ultrasound of the appendix or a CT of the abdomen and pelvis. Which one you choose might depend on the degree of clinical suspicion for appendicitis or other pathology. So if you're kind of equivocal after reviewing her clinically, you might opt for a CT because that would give you more information of other structures. Or if you're kind of 80 to 90% sure that someone's got appendicitis, you might opt for the less invasive bedside ultrasound. Bonus points if anyone can tell me who the what the sign is. So this one is a let's go back. Aptly named target sign because it's an axial section of the inflamed appendix. So what you see is thickening of the wall. So moving on to the next case now. Does anyone have any questions about that? They're all pretty straightforward. So second case now, same girl, she's now 24 years old and has presented again with abdominal pain. Past medical history is well-controlled asthma and a lap appendix 7 years ago. This time, in addition to the abdominal pain, she also has tachycardia to 140. She's febrile with a low-grade temp of 37.5, and she is extremely tender around the periumbilical region. You do some bloods and you find that her hemoglobin is mildly reduced. She's anemic with 95, white cells 28, platelets are elevated to 450, and she has some thickening of the terminal ileum with fat stranding and some free fluid in the pelvis. Anyone want to volunteer what other clinical features you'd look for to facilitate diagnosis and treatment? Vineeth Roy, do you have any ideas? Anne Abraham, are you there? Do you have any ideas?
You'd want to do a plot radio here as well.
Mm-hmm.
Just checking for like menstrual history.
What was that?
Menstrual history.
Yep, perfect. Thank you, Jay. So again, I'll put everyone out of their misery and go on to other things you want to look for. So you find that she has colicky abdominal pain, which is relieved by defecation. She has a bit of diarrhea and fecal urgency. She reports some weight change and oromucosal ulcers. So top differentials here for periumbilical pain in a young woman with raised white cell count and evidence of infection and inflammation on CT. You can read the list there yourselves, but it's mainly kind of looking at different causes of colitis and I think, stomach and terminal ileal inflammation, so gastritis and PUD. So just to flick back, so free fluid in the pelvis is a very common finding on imaging, both ultrasound and CT, and it's just basically a non-specific finding that indicates inflammation in the abdominal cavity. So in this case, she has Crohn's. I think everyone by now should have already done some study on Crohn's disease and ulcerative colitis. So features that you'd want to look for are extra-articular features of IBD, so checking her eyes for any redness or pain suggestive of uveitis, episcleritis, checking the skin, particularly on the extensor surfaces of her arms for erythema nodosum, and in rare cases you can get pyoderma. You also want to check whether she's got any features of abdominal sepsis. So in this case, she does have a fever, she does have raised white cell count, and she is clearly uncomfortable and in distress. And so I think at this point you have a pretty good grounds for starting some antibiotics to cover an empirical source of abdominal sepsis. So at this point, what you do is after, as mentioned before, the initial workup for surgical patients, you do the admission for your contact gastroenterology usually. The aim of this would be to induce remission in this lady. You get a colonoscopy with a biopsy of any lesions seen, and you'd want to do a nutritional screen just because she's at high risk of malabsorptive problems, and you already know she's got anemia, so you want to check her iron, folate, B12 and all that, and also get a stool MCS. The reason for this is that it's quite common for patients to have C. difficile after completing a course of antibiotics. And a complication of this colonization or infection is that you can have pseudomembranous colitis, which is basically can be a surgical emergency that causes severe inflammation and risk of perforation in the colon, which might present as periumbilical pain if it's the transverse colon that's affected. Anyone have any questions about that second case? All pretty clear? Or moving on then. So same lady again, she's now 34 years old. This time she's presented with perianal swelling and a tender fluctuant lump. She's also got, again, as mentioned, asthma. She's on azathioprine and sulfasalazine to maintain remission of Crohn's, and she had a lap appendix at the age of 17. So as the diligent doctor in ED, you perform a DRE. You find an extremely tender swollen lump at 5 o'clock from the anus, covered with granulation tissue, and internally there's also a palpable fibrous tract. Her bloods are significant for mild anemia, leukocytosis, and raised CRP. What would you want to look for to figure out the cause of her perianal swelling and pain? Cecilia Gomez, are you there and able to contribute some ideas? Kira McMahon. That's okay, I'm probably scaring people off by asking too many questions. So in this case, you'd want to establish the chronicity of the pathology. So, has it been slowly progressing over weeks, or is it sudden onset within a few days? Have there been any precipitating factors such as prolonged sitting, for example, during travel or trauma? Has there been any discharge from the lump? Has she noticed any pus, any fecal content? Has there been any change to her continence, either fecal or urinary? Is there any evidence that she's been having fevers or rigors at home? Has she had any dysuria or changes to the appearance of her urine? And also on examination, can you actually see an opening at the external surface where there's a lump? and the granulation tissue. In this case, what you're looking for is a perianal abscess, a fistula, anal carcinoma, or hidradenitis. In this young lady with Crohn's, though, you have a pretty high suspicion of a fistula in ano complicated by perianal abscess, so those two co-occurring.
Can I ask, sorry, on the last slide,
Yeah.
you said that there was a palpable fibrous tract. Is that not pathognomonic for a fistula?
It is, yeah.
Yeah,
I was just thought I'd throw it in there to try and make it easy. So you obviously have all these differentials. They can co-occur, as I said, fistula with perianal abscess. But other things that can cause pain and lump are anal carcinoma and infection of the skin through hidradenitis. So as I said, anal fistula in the setting of Crohn's. So I think other topics that are usually fairly commonly asked for colorectal surgery are anal fissures, hemorrhoids, anorectal abscesses, pilonidal sinuses, and rectal prolapse. So things to know for this patient are, does she have any signs of perianal sepsis? So in particular, you'd want to check, does she have a sustained fever? Is her lactate elevated? Is there any sign of sphincter injury as well? Usually the problem is that if a sinus tract forms from the bowel lumen to the skin, it can cross the sphincters, it can go around them. So there's different grades. I don't think you need to know particularly how to differentiate between them, but the fact that there is an internal opening and an external opening will by nature create a tract end injury to the muscle. And is there any history of anal warts or any unprotected sexual contact? So in terms of further investigations and management, there's basically two ways to approach this. One is that you can think about doing an MR of the pelvis to assess the sinus tract. The other is that you can do an examination under anesthesia. It's pretty common to do both because you use the MR pelvis to plan for surgery where you do the EUA. Basically, because these lesions are so painful, clinical examination without anesthesia is, I think, near impossible if you want to get a really good look with a proctoscope or something similar. So these patients are often taken to theatre. They have the sinus and internal and external opening visualized while they're under general. And then that way they can also do the either fistuloplasty or seton placement at the same time. Another good thing to be aware of is this thing called Goodsall's rule. So basically what it means is that if this blue circle here is the anus as it appears with the patient lying on their back, with the back up this side where the posterior tracts are. So fistulas that form from the posterior surface tend to have a curved path, whereas fistulas from the anterior portion tend to have a straight tract. And then if you see any sinus openings as well, laterally, that has a higher risk of it being due to IBD as well. So any questions about that one or that case? No, okay. So now we have a 55-year-old lady.
Actually, sorry, a bit late. With a patient who has a sit-on, how long would you leave that in for, or like when would you consider? Because obviously that's not going to be like definitive management. What sort of would you do once a sit-on?
Yeah, a sit-on can actually be definitive management. So what basically the concept is that you find the base of the fistula while they're under general, and then you place a large plastic, almost suture really, through that and then tighten it. So the idea is that it brings that surface outwards and promotes granulation and scarring, And the idea behind that is it will close the tract. And so what happens usually is someone will be booked in to have an elective CTOM placement, and then they'll be reviewed in another week or so in clinic. They'll have it tightened to progress the fibrosis and scarring of the tract, and that will continue until the CTON can be removed. Sometimes it takes weeks, and sometimes they need to have it done several times if it's a particularly nasty fistula. Does that make sense?
Thank you.
Yeah, almost like braces for your bum. All right, next case. So Kate now is 55. She's presented again to ED with left lower quadrant pain of the abdomen. She's got a history of Crohn's IBD, which is currently in remission, and she's off medications for that. Asthma, again, no regular meds. She had an lap appendix at the age of 17 and a fistuloplasty in the end at the age of 34. So at the moment, she's febrile in ED. She's got a tender left lower quadrant on palpation, but otherwise not much on physical exam. In terms of investigations, she's got a white cell count of 18 and a CRP of 60. So again, high suspicion of infection or inflammation. She's waiting for a CT abdomen and pelvis. You've been contacted to come and assess her. What further information would you want to do to facilitate diagnosis or initial treatment?
Do you want to ask about her bowel habits, specifically if there's been any blood or mucus?
That's a great start. Thank you, Jessie. So we've got change in bowel habits. How about on exam? Anyone want to say what you'd look for?
Is she hemodynamically stable currently?
Yep. Just in terms of vital signs, the only derangement is a temperature. But yes, very important thing to exclude.
So any like peritoneal signs like percussion tenderness?
Yeah, great. So we've ruled out basically sepsis and peritonism, and we're also looking for bowel changes. Great. So recent bowel changes, PR bleeding or melena, alterations to diet, and also looking for atrial fibrillation signs. So this is a bit of a weird one, but basically the thinking behind this is that with anybody who has left lower quadrant pain, pretty much the biggest organ there is your descending colon and the sigmoid colon. And if the colon itself is what has disease, then there's so many causes of it. There's cancer, diverticulitis, inflammatory bowel disease, ischemic colitis, gastro. So with ischemic colitis in a lady of this age, looking for whether there's any risk factors for an embolic event. So as we said before, we want to do some checking for red flags. So we mentioned sepsis. Also, another big thing is fistulation. So bowel to bowel, bowel to bladder, or bowel to reproductive tract, more commonly in women. But in this case, if there was bowel to bowel fistulation, you could see blood and stools due to erosion of the wall. You'll see PV pain or discharge in women who have bowel to uterus or bowel to vagina fistulation. You can see dysuria, bubbling or brown discoloration, and flecks of brown in the urine as well. This is surprisingly common with diverticulitis, that they get basically one diverticulum that kind of enlarges over time. They might get, brief episodes of pain, and then it erodes into the adjacent organs, and you get this kind of presentation of pain and stool, bladder, or reproductive organ change. So in terms of further investigation, you just want to do a CT to check what's exactly going on inside the abdomen, and also a septic screen, which would in this case include a stool gnat. I don't know if you guys would care about this yet, but when you're ordering stool samples to be investigated, you actually, for some reason, can't do a stool MCNS. The lab will only run a stool gnat, which includes specific bacteria parasites, viruses, and C. difficile if you ask for it. So stool MCS is not an investigation we do anymore. So as you guys might have already suspected, in this case, she has an episode of acute diverticulitis. I hope everybody knows by now the difference between diverticular disease, diverticulosis, diverticulitis, and all that. But if not, I have this handy guide here. So I think diverticulosis, which is asymptomatic, is extremely common, affects something like 80% of people over the age of 60. Occasionally people can get spasms causing a episodic kind of chronic to subacute diverticular pain, usually left lower quadrant. In hospital, we often see acute diverticulitis or pericolic abscesses. Occasionally, you also get perforation, fistulation, and bleeding from diverticular diseases as well. Any questions about that one? No, okay. So case 5. So Kate has aged another 10 years and she's now 65. She has represented again for severe abdominal pain. She has a history, as we know, of Crohn's, asthma, left appendix, fistuloplasty, and acute diverticulitis. So when she's come in today, she's quite distressed. She's got a rigid and distended abdomen. Her investigations are significant for a mildly raised white cell count of 12. Lactate is raised at 2. Her CT is pending. So what would you want to look for on either clinically or in terms of further investigations?
Whether she's peritonitic?
Yep. So we know that she's got a rigid abdomen. She's got a distended abdomen as well. Anything else that people would be interested in?
Like an upright abdominal X-ray to look for air under the diaphragm.
Okay, yep.
Abdominal X-ray for as well for like air fluid levels.
Yep.
If the lactate is 2, was she? Did you say she was hemodynamically stable?
Good question. So basically, lactate is a marker of either ischemia or sepsis because it's produced in states that are high in anaerobic respiration. So commonly, what you'll see it in is patients with known infection that have become rapidly unwell. You might see raised lactate. Also in ischemic events. So whether that's ischemic, muscle, bowel, heart, anything like that can produce raised lactate. It's not necessarily a reflection of hemodynamic stability, but it's often associated with in patients who are otherwise extremely unwell and have hemodynamic instability. Yeah, if that makes sense.
So you're saying at the moment she is stable?
Oh, sorry. At the moment, Kate is hemodynamically unstable. So let's say she's got a blood pressure of 90 on 52. Her temp is 37.8. She has a resp rate of 30 because she's splinting from her abdomen. She's also got a heart rate of 150.
Okay. Would you start a sepsis protocol straight away, or do you do immediate surgical review and intervention?
Yeah. So I think just because in any patient who presents acutely unwell, you always do the sets of admission bloods and whatnot. So in this case, we think it's probably clearly an abdominal source that's causing all of her symptoms. So you might not necessarily need to order things like a chest X-ray, but you would definitely want to do things like urine, bloods, and then just the keeping an eye out for symptoms of other causes of sepsis like lung. Yeah. So we'll move on to the next slide. So she tells you that she's had a lot of nausea and vomiting. In terms of her bowel motions, she's not passing much wind, and she last opened her bowels yesterday. She's had no PR bleeding. In terms of her weight, she's noticed a loss of maybe 15 kilos in the last 6 months, but she's not exactly sure because for some reason patients never know how much they weigh. She hasn't had any recent medication changes, infections, or antibiotics. So at this stage, in a patient who has severe abdo pain, some signs of peritonism, she's got nausea, vomiting, weight loss, you'd be thinking bowel obstruction would be the top cause. There's also things to rule out with toxic megacolon and pseudo obstruction and paralytic ileus. So the questions about recent infections or antibiotics relates to C. difficile infection, which is the precursor to toxic megacolon. Pseudo obstruction can be precipitated by medication changes and electrolyte disturbance. So red flags to exclude. We talked about some B symptoms. So she's had a bit of weight loss, whether they have any obstipation, whether they have any peritonism. So you do a CT on her, find that there's gross dilatation of the small bowel and ascending colon, and there is a transition point in the transverse colon where they can also identify an obstructing lesion. On bloods, as I mentioned before, you just want to exclude electrolyte disturbances like hypokalemia or hypomagnesemia, because these are very common causes of pseudo-obstruction. So you just replace them as needed. That goes without saying. So in this case, yes, Kate has malignant LBO secondary to new diagnosis of colorectal cancer. This would be a surgical emergency. So we'd want to contact the ASU registrar for a general surgery admission and then get her onto the wait list for a bowel resection, basically. Any questions about that case?
Can I ask where the rigidity comes in?
So rigidity is basically when you have someone who has an extremely painful abdomen, usually in peritonitis. They kind of want to prevent any sort of movement because that would precipitate pain. So if they're in pain, they're not moving, then when you walk into the room and look at them, you can see that usually they've got their knees drawn up, they've got their arms extremely still by their side, and they're taking rapid shallow breaths in order to avoid any changes to the intra-abdominal pressure.
Thank you. So are we saying that this person is peritonitic because the bowel obstruction is so large that it's pressing against her peritoneum, or?
Yeah, so in this particular case, I guess the scenario I was trying to make up was that she was about to perforate from the degree of distension in the colon.
Okay, thank you.
No worries.
For this case, if they're in severe abdominal pain and they have increased lactate levels, would you consider mesenteric ischemia as one of the differentials?
Yeah, so basically it's, as I said before, any cause of ischemia is of concern, and then we already know that it's an abdominal cause. So, the same red flags as before, where you look for risk factors for embolic events or atherosclerosis, like whether she's had any episodes of AF or has persistent AF, whether or not she's had previous cardiac history or PVD. Those things would come into play there.
Yep, and it's also an acute onset, if I'm not wrong, for mesenteric ischemia.
Sorry, what was that?
Would there be an acute onset as well for mesenteric ischemia?
Yeah. So there's two types of mesenteric ischemia. There's acute and chronic. So acute mesenteric ischemia is usually basically someone has some kind of event where they block off, one of the arterial territories. So let's say she blocks off her SMA and infarcts, part of her duodenum and I think the inferior portion of the stomach or something like that, you know, then it would be an acute event, and you'd see this kind of picture where you have the sudden onset pain, peritonism, raised lactate and whatnot. Chronic mesenteric ischemia, you would probably see postprandial pain. So when there's increased oxygen demand in the gut after eating, that's when people tend to notice that their blood supply is insufficient, and that's when they get the symptoms of severe pain. And that's usually kind of develops over months. There's two different pathologies there for mesenteric ischemia. Okay. So case number 6. So Kate has aged again. She's now 70 years old. This time she's presenting with a painful abdominal lump. In terms of past medical history, as we already know, all the above, plus in addition to her presentation from malignant bowel obstruction, she ended up undergoing a Hartmann's procedure. Basically, that just means that she's had part of her descending colon and the sigmoid and rectum removed, and she has now an end colostomy. So looking at her, she's got a tender and firm lump on the anterior abdominal wall adjacent to an old surgical scar. She hasn't had any investigations performed yet because ED has been very busy. So I think at this point, it's pretty high likelihood that she has some kind of hernia, right? Because I've already mentioned that it's next to the scar. So things that you'd want to ask about are risk factors and signs of the hernia. So did she have any issues with wound healing postoperatively? So, you know, some patients might have had infection and then dehiscence and then had a vac dressing for a month or something like that. And then now they've come back with this painful lump. Does she have any risk factors for increased abdominal pressure, like obesity, occupations where you have heavy lifting, or any previous pregnancies that would weaken the abdominal wall? On exam, is there a cough impulse? And looking at, are there any other lumps around her body? So thinking hernias, lipomas, cysts, or cutaneous manifestations of different forms of cancer. So in this case, what you'd want to make sure of is that she doesn't have bowel incarcerated within this hernia, which again would cause severe pain, likely associated with nausea and vomiting. Depending on what's happening clinically, you can try to do a manual reduction at the bedside. So if you don't think that there's bowel, you know, you could, if it's just a fat herniation, basically, then you can try and push it back through the sheath. If you're not sure, you can always do a little bedside ultrasound looking for a bowel loop or gas. And if you think that she might need an operation, we usually go straight to CT because that will help us to plan an approach. So just, I think I already heard someone talking about hernias before in the pediatric setting, but good to know about them and also other common types of abdominal wall hernias. So I think the buzzword for this is the Hasselbalch's triangle. I think everyone might have heard of this by now, but basically it's the site of direct inguinal hernias. So it's the pink one that you can see here. And as you can see, they've nicely colored it in. So its borders are the inguinal ligament, the vessels, and the rectus abdominis sheath. Any questions about hernias? Just as a aside, in outpatient settings, most surgeons would probably say that an ultrasound is not very helpful. The reason for this is that when people have a hernia, it's either clinically appreciable, you can reproduce it with increased pressures, such as when you're standing or when you're pushing on the abdomen. Or it's irreducible, in which case it's easy to appreciate, or it's intermittent. And if you're not sure that it's a hernia because you can't see it on clinical exam, and you go send them to get an ultrasound, they probably won't have a hernia on ultrasound either. And so the report will just say possible sliding hernia, which again, not very helpful because it doesn't confirm or deny its existence. So it's not really something that we like to jump to in real life, even though it is a very commonly ordered investigation. So last case for poor old Kate. She's now 80 years old. Again, abdominal pain. We know her history quite well at this point. She's had quite a protracted course. She's got Crohn's, asthma, lap appendix, fistulopathy. She no longer has diverticulitis because she doesn't have a descending colon anymore following a Hartmann's for malignant bowel obstruction due to colorectal adenocarcinoma. And she also ended up getting that incisional hernia repaired at the ripe old age of 72. This time she's come in because she's got severe nausea and vomiting and abdominal pain. And while you're assessing her, she's still vomiting. She's got bags of green fluid coming out of her. When you palpate her abdomen, it's generally tender. Bloods are not too exciting. She's got very mild anemia, 112. White cell count's normal. Her potassium is a bit low at 3. And so in this case, it's pretty clear that she's got reduced potassium because firstly vomiting, secondly oral intake has reduced. So what further information or treatment would you like for Kate?
For further investigations, you mean?
Yeah, or bedside features,
Yeah.
investigations, anything.
Yeah, and a standing or upright abdominal X-ray looking for dilated loops of small bowel, air fluid levels. To do an ECG just to make sure she's not getting any cardiac side effects from the low potassium. And then probably start some. I'd also check her magnesium. Start some mini bags of potassium.
Great. Yeah. So you're going to regret answering now because I'm going to ask you a follow-up question. What features would you expect for low potassium of 3?
Yeah, so we'd expect enlarged T waves, enlarged P waves, flattened T waves, potentially you wouldn't get a wide QRS in hypokalemia, maybe a U wave.
Okay. So those are all good answers. Usually at 3, we wouldn't expect to see very much, but you could get any of those features. Also, a little bit of PR prolongation is pretty common as well. So always, comparing to old ECGs to check whether or not these changes are acute or chronic. So I think on further clinical assessment, she reports that she's having paroxysms of cramping pain that come in waves every 5 to 10 minutes. As we know, she's got nausea, vomiting. She hasn't had much to eat or drink in the last 48 hours due to this nausea and vomiting, and she's quite dehydrated. So when people present with nausea, vomiting, diarrhea, obviously we always want to give them a bit of fluid resuscitation to firstly correct the level of dehydration, and then secondly, maintenance fluids. So in her case, obviously, we could start with the mini bags of potassium and magnesium, run them in as a bolus. Sorry, not as a bolus, but run them in on top of a bolus. So, say we'd want to do 250 mils an hour of Hartmann's and also a mini bag per hour. That way, she's getting enough electrolyte into her. After a certain point, you'd switch fluids, obviously, but that's a good one to start with. Differentials for this would be gastroenteritis, paralytic ileus, mesenteric ischemia, acute pancreatitis, constipation, and for some reason I forgot to put small bowel obstruction there as well. So Again, always need to exclude bowel perforation or necrosis, because then that would be a surgical emergency for which we'd have to resect a portion of her bowel. Commonly, the approach we take is the drip and suck, so NG2 decompression and potassium-rich fluids. This conservative approach is effective for about 70% of small bowel obstructions. Alternatively, you can also do nasogastric gastrographin with serial X-ray studies. So the idea of this is that it's both diagnostic and therapeutic, because you get to see whether there's a transition point in these small intestines. And you also have a therapeutic effect with the gastrographin. I can't remember the exact mechanism, but I think it's to do with the electrolyte composition that's the gastrographin sits in. You can also quite commonly do a CT abdo-pelvis. In hospital, particularly since we're in Australia, which is a fantastically rich country, we hardly ever actually do plain X-rays, particularly erect ones, because it's not got the best sensitivity. And also trying to get patients who are in pain and vomiting to stand up still for X-rays can be quite difficult. So we get, low quality one because they're slumped over from their abdominal pain. So as I said before, if the bowel is threatened, it's an emergency, get them into theatre and cut out that piece of necrotic bowel. If the bowel's unharmed, then you would do the drip and suck approach and observe them with a strict intake and output on the ward. And depending on how much was coming out of their NG tube, that would determine whether you leave it on free drainage, whether you give them a spigot and 4 hourly aspirates, or whether you give them meal by mouth with ice chips or clear fluids or free fluids and that sort of thing. So entirely guided by the clinical response, which would, be things like borborygmy, passing wind, passing stool.
Is the NGT, sorry.
Go ahead.
Is the NGT decompression the main therapy for the nausea, or do you also consider adding antiemetic therapy?
Yeah.
And
so I'm not sure if you saw the very first slide. This is for every single surgical patient, what to do. So PRN, analgesia, antiemetics, appearance, always. So I think my personal preference would be ondansetron IV 4 to 8 milligrams every 4 hours with a max daily dose of 32 milligrams. The only problem is that ondansetron can sometimes be a little bit constipating. It's not really an effect that you notice with everybody, but sometimes it can be. So an alternative to that is then metoclopramide. Again, because it's a dopamine agonist, you sometimes get dystonic reactions, which occur in young people predominantly, or you can get Parkinson type reactions, which occur in old people. Failing those two, which would usually be first or second line for most people, you could also use things like droperidol, domperidone, prochlorperazine, cyclizine. Kind of keep going down the line until you find something that relieves their nausea. Does that answer your question?
yes, thank you.
No worries. So if we come back, where were we? There we were. So, yep, diagnosis was an adhesional small bowel obstruction on a background of IBD and previous abdominal surgery. So I think most people would probably know this by now, but adhesions are just the peritoneum's reaction to any form of inflammation. So you don't even have to have surgery to have adhesions. It can be from really commonly from endometriosis and PID, in this case, because she's had Crohn's disease and previous abdominal surgery, and also previous hernias, extremely high risk, and will probably have recurrent episodes. So there's just things to know for this topic would be small bowel obstruction, common causes, etc., how to treat them, and common surgical complications, because this is probably one of the most common causes in surgery. So that was the last case actually. Does anyone have any questions or comments